This is Quality Talk,
a podcast dedicated to advancing better understanding of healthcare.
Did you like my Ryan Seacrest impression? Instead of "This is American Idol," I said, "This is Quality Talk."
Oh geez, I let you do the intro one time and you're already acting like a celebrity. Let's not get too excited here.
Well, I am excited because this is the first Rachel and Jodie podcast. I'm Jodie Jackson, the host of Quality Talk, marketing specialist at Primaris Healthcare Business Solutions. My boss here, Rachel Verslues, has introduced the first 32 episodes of Quality Talk. Today I am taking that honor. Rachel, how am I doing?
Well, hey guys, as you've probably heard before, I'm the marketing director here at Primaris, and I'm really excited to be here today. In response to your question, I'd say you're doing pretty good. From you walking into my office one day when you were new to our team and marketing and saying, "Hey, I think we need a podcast," to today where we have more than 30 podcasts out there with already amazing guests and a plethora of topics such as macro MIPS, health disparities, Medicare, patient safety. I'd say we're on the right track.
And we are on a good track. I keep track of these recordings on the time, and I will note that at 1:20 of this recording, you used the word plethora. And I'm surprised it took you that long to say it. We're going to get ready to launch a new campaign here fairly soon, asking, do you have your lineup ready?
That's right.
For quality reporting success? And it has a very deep, definite baseball theme, because we're talking about a team and lineup. So I thought at this time we would sing "Take Me Out to the Ball Game."
Oh, Jody.
Maybe we should save that recording for another day.
Yes.
Okay. Well,
I'd like our listeners to keep listening.
Okay, they are. Well, we also should point out that this is the first Quality Talk podcast that is being recorded on video. And here in the room with us is our brand new team member, Amanda Teal, and our other marketing specialist, sound engineering, video production guru, Adam Voigt. And so I know they're going to be disappointed that we didn't sing "Take Me Out to the Ball Game."
Well, let me point out, you actually made me do my hair for once and decided to put all the pressure on me, put everyone in the room. So thank you for that, by the way.
You're welcome.
Performance reviews will roll around.
I'm looking forward to that one someday, but I think I'm out that day. Whenever it is. This is episode 33. And Rachel, what are we going to talk about today?
Well, I know we often talk about our data abstraction services and how we help people with quality reporting, but I don't know if we've ever actually broken down, like, what does that mean and what does that entail? Plus, I thought it might be kind of nice to talk about, like, what's it like to partner with Primaris and how do we deliver those services? As several of our clients say, it's like we're sitting in the cubicle next to them or we're part of their actual staff.
Well, that's kind of an impressive feat because we have our roots here in the Midwest, but we have a nationwide footprint in 27 states, so that's a lot of cubicles to be in next to you.
Well, that's right. Well, one, I think our attention to detail and even more so becoming an active member of our clients' teams is one thing that really sets us apart. It's been like that since the beginning. And we even saw proof recently in a customer value proposition survey that we did. In that survey results, our customers had showed us that our partnership culture is one of the greatest things that they find as a differentiator for us.
Well, when did we get started with this, and how do we even get into the data abstraction business?
Well, Primaris has been working in healthcare quality reporting for many, many years now. You know how we say, oh so often in our marketing materials, more than 30 years. During our beginning as a trusted partner with CMS as the Quality Improvement Organization, the QIO for Missouri, and our work with the Joint Commission, we were already doing pilot projects, application testing, all kinds of initiatives around core measures and new registries as they're developing, and we continue to do that today.
So let's take a step back in time and maybe first talk about how this all started.
Okay, yeah. Well, you're taking us back to 1979 when the Healthcare Financing Administration, HCFA, was established to administer Medicare. HCFA began building a network peer review organization, another acronym for you, PRO, to review Medicare cost and patient care. The idea was that they would control cost and improve patient care.
And HCFA was the forerunner of CMS, the Centers for Medicare and Medicaid Services.
Right. And when Medicare and Medicaid programs rapidly expanded into the early 1980s at greater and greater cost, HCFA decided to strengthen their PRO network by working with contractors in each and every state. The PRO that was formed in Missouri was the Missouri Patient Care Review Foundation. Try that acronym out. That organization and the tasks that were charged to it evolved over the next several years, and each step was bringing the healthcare system closer to value-based care, which we all know is shifting from that fee-for-service model of paying for the volume of care to paying for proven quality success care.
You know, way back in episode 1 of this podcast, our CEO, Rick Royer, elaborated on our new ebook, The Primaris Story, which you can find on our website under Who We Are.
Yes.
And he explained that in 2001, HCFA was renamed CMS. Then in 2004, the MPCRF changed its name to Primaris. It's much easier to say now. So when we talk about Primaris being a pioneer in the shift to value-based care, we really do have the years of experience and the expertise to back that up.
Yeah, and we've seen the progression of rules and regulations for hospitals and clinicians to show that they're providing quality care at a lower cost. The way to measure that quality was in seeing what the data said. That's kind of where quality reporting began. Data from specific quality measures are reported to CMS as core measures, and data are also reported in dozens of different registries. It didn't take long before the hospitals were overwhelmed by all these requirements and all these new measures and this reporting they had to do. I remember I recall Rick saying, hey, this is getting a little more complicated than someone from our medical records department doing this. Is there a way we could outsource this to someone?
And so what work is being outsourced? What is data abstraction? Why can't hospitals do this themselves?
Wow, just throw some heavy questions at me there, Jodie. Okay. Well, data abstraction is extracting, reading, reviewing, aggregating, like specified required sets of data from a patient's charts. And when you ask what's being outsourced, that can mean many things because you can outsource many things. But for what we're talking about today, the actual task of completing data abstractions and reporting data is what we're talking about being outsourced here. Oh, yes, I'm sorry. Also, hospitals can do it themselves, and most of them do. The issue is, it's hard. The push for reporting data is becoming stronger and stronger, and measures and registries, they're constantly changing and evolving. They have new specifications, the manual's been updated, they've done away with this core measure, but now they have this registry. Having to deal with all of that is a challenge, and then having enough staff to do it is a challenge. Having the right staff to do it is a challenge. And stay on top of all of that and not let your quality of care for your patients be affected. That's the challenge here. And that's where we discussed before that people saw a value in having a qualified, experienced team of people to do this for them and why that was so beneficial and effective for them.
And you know what? One thing that I think is really impressive is the way that our team responds to this, we call it the alphabet soup of MIPS and MACRA, the alphabet soup of all quality reporting. And I think some of those acronyms are maybe created accidentally, just like the way you almost created the word registries. That was really good.
I'm going to say it's because I think faster than I talk, but I'm not sure. That's a pretty close
I don't think anybody thinks as fast as you shouldn't say that about your boss, right?
Again, performance review.
What if a client, though, is unsure that they want to outsource? They just need help catching up, maybe? Maybe they're not sure they want a full-fledged partnership. Can we help with that?
Yeah, we actually can in many ways, Jodie, but I'd actually kind of like to take a moment and just kind of explain a little bit how we do that, how we actually do it. So we have a dedicated team for every client. So once a client starts a partnership with us, we have a dedicated team for them. And in most cases, our team members actually become a part of like their system. Like they may even use their email addresses, because that's how we're able to obtain that patient's data, or those patients' data. Having worked with so many facilities over the years, our experienced team, they're very well versed in more than 120 EHRs. We really truly work hand in hand with their teams daily. So let's get back to your question though. So what if somebody doesn't know if they want to jump full-fledged in? What if they just need a little help? What if they're just behind? We truly customize every partnership we have to each system and what their needs are. There's sometimes where we do all the quality measures reporting with that client. There's instances where maybe we only do it for a specified amount of time. Maybe they just got 6 months behind for whatever reason, or they have someone going on maternity leave. There was a situation where they had an employee they knew was going to be out for 12 weeks for a surgery. So sometimes we just are kind of on as retainer, if you want to say it that way, with those clients that if they ever need us for a short amount of time, we are able to do their abstractions during that time, but maybe not full-fledged. Another case where I've seen a lot of people begin as our clients is they can do a lot of their quality measures, but there's some that are very, some more complex, complicated, let's say sepsis, for example, that are really challenging and are very complex. And so people may still have their team that does a lot of their reporting, but we might just do specific measures for them. And then what I've seen more often than not when we have a client begin that way is once they see how great it is to have us do that one, they slowly are adding the other ones on until we're full-fledged doing all their reporting. But there really are all those options out there for what a system might be needing our help with at the time. Another thing we can do, and I know we've done well, is sometimes we just go in and train their staff. So they have the staff, but maybe it's just really hard, like I said, with all the updates and all the changes and all the additions and deletions. We can go in and train their staff on how to do the abstractions themselves. And I know we've done things like that also. We just want to be there to fill whatever void it is they have and not create another hat for someone to wear.
Well, and speaking of too many hats, we have one client I know I've talked with she works at a critical access hospital in northern Minnesota. She is the charge nurse, a floor nurse, an ER nurse. But wait a minute, she's also the quality director, and she's also the lead trainer, and I think she even does handle some of the abstraction duties.
Unfortunately, that is what we see time and time again with a lot of clients when we first start working with them. I know in a lot of cases, when I've spoken with people at the NCR conferences, for example, so many of them are cath lab nurses all day long, but yet they still have to go get the data abstractions done and things like that. So that's a very common thing. And funny, that's actually where we get a lot of our marketing content, from conversations like that.
Well, speaking of our interactions with our clients and so on, how do we use our daily work with them to complement our marketing messages and to fashion our message to them?
Well, one of the biggest things in marketing, and truly any part of a well-run business, customer service or anything, is relate with the customer, relate with your audience, feel their pain points, connect with their concerns and challenges, engage with educating them on what they want to know about, what they need to know about, not what we think that they should know about. I try to use our team's daily interactions with clients, our sales team's feedback that they get from potential clients, conversations we have at trade shows, analytics, seeing what pages on the website are they going to, what are they downloading, what blogs are they reading the most. I try to use any of the actions that we get from our clients in any way to determine what information we're providing for them out there.
Sure. And you bring up a great point, not just for marketing, Rach, because all this talk about data, measures, registries, and processes, it seems like the patient has gotten lost in all that somewhere.
Maybe that's the reason we did Year of the Patient as one of our campaigns, huh?
Good idea.
But no, we hear that from patients and from providers. The physicians in hospitals that spend hours and hours each week going into the EHR systems, working on pulling the data and working in their records, but truly that data is just a set of numbers on a screen or on a spreadsheet, unless they're doing something with it to improve care. I mean, that's what quality reporting is truly all about.
And I guess that's why we say let Primaris take care of your data so you can take care of your patients.
So true, Jodie. The alphabet soup, as we like to call it again, of the colorful acronyms is so overwhelming for everybody, but our team's got it. We have the experience, we have the background to do this. They're more than just letters to us. We know the nuts and the bolts of MACRA, MIPS, QPP, and more.
Well, I think that there are more acronyms out there to track down today.
Is that like TTYO? I feel like you're trying to close us out here.
Yes, but first I'm going to SMH. You can find more about our services as well as our blog, Quality Today, on our website, www.primaris.org. That's the first time I've been able to say that part of the podcast. Mm-hmm. And you notice, unlike
kind of
you,
like magistries.
Unlike you, I only said 3 W's. I think you've introduced it with www, but people know what we're talking
Performance
about. Right?
review.
You can also find us on Facebook, Twitter, LinkedIn, and Google+. Mm-hmm. Our Twitter handles for the Quality Talk podcast is @TalkingQuality, and our Twitter account for our Primaris business is @Primaris_health.
I have trained you well.
Well, and now you get to wrap it up.
Okay, well, first, thanks, Jodie. Thanks to you and all the work that you and the team, Adam and now Amanda, that you guys do on the podcast. And thanks for inviting me to be a part of the show. I've really enjoyed diving into talking about how Primaris helps with quality reporting demands for health systems. And I hope that the audience out there has found something informative in this. If you'd like to learn more, if there's something that struck a chord with you, we'd love to hear from you. We'd love to connect with you. Please reach out to our team at engage@primaris.org. We offer free consultations, and we'd love to learn more about how is your team tackling, quality reporting and all of its demands. Maybe there's a way that we can help. And as I end our time here today, folks, remember, Primaris is our partner in healthcare quality. That's a wrap.
Now for a song.